Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Nayara de Oliveira with the New England QIN-QIO. This is the second webinar of our 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's webinar is an introduction to antimicrobial stewardship in long-term care. What is antimicrobial stewardship and why is it important? Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded and the presentation will be available within a few business days. During the presentation, all phone lines will be muted. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Alizi Victor from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. We will also have time for questions at the end of the presentation and will open the lines back up. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Now, to introduce our first speaker, I'm going to turn it over to Melissa Cumming from the Bureau of Infectious Disease and Laboratory Sciences in the Massachusetts Department of Public Health. Melissa?
Good morning, Nayara. Thank you so much. On behalf of the Massachusetts Department of Public Health, I'd like to welcome everyone to the second webinar in our series, Navigating Infection Control and Antimicrobial Stewardship. We appreciate your participation and your commitment to this program. I'd like to introduce first Dr. Shira Derone. Dr. Derone is a physician in the Division of Infectious Diseases at Tufts Medical Center. She has also been the physician head of the Antimicrobial Stewardship program there since 2005 and is the Associate Hospital Epidemiologist. In addition, we also have Dr. Kara Bolak. She is the pharmacist head of the Antimicrobial Stewardship program at Tufts Medical Center, as well as the infectious diseases pharmacist for the institution. And with that, I will turn things over to our speakers.
Thank you, Melissa. So today we're going to talk about an introduction to antimicrobial stewardship in long-term care. We're really going to get into what is antimicrobial stewardship and why is it important. So let's jump right in. We have a few learning objectives today to define the concept of antimicrobial stewardship, to describe the need and rationale for antimicrobial stewardship in long-term care, to interpret the CMS requirements for antimicrobial stewardship in long-term care, and to prepare for implementation of an antimicrobial stewardship program in your facility. So clearly, we know that there is a problem, and we're going to frame that for you today. In this nice infographic from the CDC, we see some numbers related to antibiotic stewardship or antimicrobial stewardship in nursing homes. 4.1 million is the number of Americans admitted to or residing in a nursing home in a given year. Up to 70% of those nursing home residents received an antibiotic during the year. Up to 75% of those antibiotics are known to be prescribed incorrectly. So the CDC recommends 7 core elements for antibiotic stewardship in nursing homes. We'll get into those in more detail. Meanwhile, we've got a population that keeps aging. And if you look at this graph of age over time, and the number of people age 65 and over in millions, and the number of people age 85 and over in millions, looking at today and projected up until 2050, you can see that we're looking at a future with a much more aged population, and therefore a larger chunk of the population living in long-term care facilities. At the same time, the bugs are becoming harder to treat. We are seeing more and more bacteria that are resistant to what used to be our usual antibiotics. On the left, you see a graph representing the percentage of Klebsiella, which is a gram-negative pneumonia isolates that are resistant to third-generation cephalosporins, an antibiotic that is typically used to treat these types of infections. And on the right, you actually see the very steep increasing curve of Klebsiella that are resistant to carbapenem. So not the usual antibiotic, what we consider the last resort antibiotic. And you can see that those curves there are divided into patients who are inpatients versus outpatients versus ICU versus nursing homes. Now, we wouldn't really care so much about increasing resistance if we thought we were going to be able to develop antibiotics quickly enough to take care of those organisms as they develop resistance. But the reality is that we really are not. And this graph shows the number of FDA approvals for new antibiotics over time. And you can see that antibiotics are not being developed at an increasing rate to match the increasing rate of resistance. In fact, quite the opposite. And so what we say in our field is that drug development pipeline for antibiotics, it's broken. It's really drying up. We've got a big problem here. And we need to solve that with things other than drug development. Dr. Margaret Chan, who was the director of the World Health Organization, referred to our future as a post-antibiotic era. And she said that that means, in effect, an end to modern medicine as we know it, where things as common as strep throat or a child's scratched knee could once again kill, like they did in the pre-antibiotic era. And that's a scary thought. The CDC put out its first antibiotic resistance threats report in 2013, and it provided some national summary data, at least over 2 million illnesses caused by antibiotic resistance, with 22,000 deaths. At least 250,000 illnesses related to Clostridium difficile infection, with 14,000 deaths. The CDC went on to categorize bacteria and fungi into levels of threat: urgent, serious, and concerning. And if you look through these lists here, you'll see a number of very familiar organisms here, organisms that are plaguing long-term care facilities, such as in the urgent category, Clostridium difficile, carbapenem-resistant Antibacteriaceae, which you may not have seen, but you will. In the serious threats category, we've got organisms like Acinetobacter, fluconazole-resistant Candida, extended spectrum beta-lactamase-producing Enterobacteriaceae, which you've probably all seen, VRE, which you've certainly seen, drug-resistant Pseudomonas, MRSA. Now, these increasingly resistant organisms force us to use increasingly broad-spectrum antibiotics, and to think about using antibiotics sometimes in residents or patients in whom we're not certain there is an infection, because we're worried about the downstream consequences of leaving an infection untreated. And yet, just thinking about antibiotics alone and the adverse events associated with those antibiotics, the CDC actually states that antibiotics are responsible for almost 1 out of 5 emergency department visits for adverse drug events. So setting aside the fact that antibiotics may contribute to antibiotic resistance, antibiotics alone contribute to many adverse events in our healthcare community. So in this infographic, we see how antibiotic stewardship in a facility can decrease antibiotic resistance, Clostridium difficile infection, and costs while increasing good patient outcomes. When we decrease antibiotic use, we decrease the promotion of resistance, and we decrease cost, and we decrease antibiotic-related adverse events. Promoting antibiotic best practices is the first step in antibiotic stewardship. And that means, at a minimum, ensuring that all orders have a dose, a duration, and an indication, that you're getting cultures before you're starting antibiotics. And it's really important to take an antibiotic timeout, where you're reassessing antibiotics after 48 to 72 hours. A patient or resident has been started on an antibiotic, and at 48 to 72 hours, somebody is asking the question, does this patient still need antibiotics And do the antibiotics need to be this broad? Or can I do something with the information I now have? So an antibiotic stewardship program is a win-win for all involved. And many studies, a very large number of studies, have shown the cost savings associated with antibiotic stewardship programs. We all know that implementing antibiotic stewardship takes financial resources and human resources and time. But it has been shown time and time again that once those initiatives are in place, it is a cost savings for facilities. And in the University of Maryland study, they actually showed a savings of $17 million over 8 years. And studies have even shown that when an antimicrobial stewardship program is eliminated in favor of other initiatives, costs will go back up. So antibiotic stewardship helps improve patient care, shorten hospital stays, thus benefiting patients as well as hospitals. Now, antimicrobial therapy is a balancing act. It is not easy to determine what to do on a case-by-case basis when you're looking at a patient or resident who appears to have an infection, because we are always trying to choose the appropriate initial antibiotic that's going to cover that infection, knowing that resistance is out there, knowing that a resistant infection is possible in any patient, while improving the patient outcomes, while doing the right thing for healthcare, but on the other side, avoiding unnecessary antibiotics, avoiding the adverse patient outcomes, avoiding the increased cost. And yet we know that antibiotics are a risk factor for the acquisition of multi-drug-resistant bacteria. So we see a resident in front of us. We think they might have multi-drug-resistant bacteria. We want to give them an antibiotic, but we know that that antibiotic is going to create multi-drug-resistant bacteria. And in case you weren't convinced, here are, in one study, a list of the risk factors that were associated with acquisition of multi-drug-resistant gram-negative bacteria in a cohort of patients. And what you can see is that antibiotic exposure had the highest odds ratio, in fact, the only statistically significant factor predicting antimicrobial resistant bacteria. So we've got this slippery slope that I think I've just described to you, where you give somebody antibiotics, you increase the chance that that person then becomes colonized by a multi-drug resistant organism. Once somebody is colonized by a multi-drug resistant organism, they're at risk for a multi-drug resistant organism infection, which then lands them in the hospital. And then they're discharged to long-term care, either initially or back to the long-term care facility they came from. And then what you've got there is transmission of those multi-drug resistant organisms to and from the resident across care settings, which is why this is a public health issue. So the White House got involved in 2015 and published their National Action Plan for Combating Antibiotic-Resistant Bacteria. And Goal 1 in the White House Action Plan, Objective 1, was to implement public health programs and reporting policies that advance antibiotic resistance prevention and foster antibiotic stewardship in healthcare settings and the community. And that is why we are here, Kira and I, partnering with the Department of Public Health and QIN-QIO to give you these webinars and to help you to figure out how to implement stewardship in your facilities. All part of the grand plan implemented by the White House. So we have some major opportunities for improvement here. We know that 20 to 50% of antibiotic prescriptions in acute care are considered inappropriate or unnecessary. We know that 50% of outpatient antibiotic prescriptions are considered inappropriate or unnecessary. And we know that 50 to 75% of antibiotic prescriptions in long-term care are considered inappropriate or unnecessary. And your tax dollars are at work here. Multiple initiatives are happening simultaneously throughout the different healthcare settings to tackle each of these issues. The Wall Street Journal even picked this up in an article in 2015, publishing on the new push to stop overuse of antibiotics in nursing homes, with up to 75% of prescriptions incorrect. I'm going to turn it over to Kira, who's going to talk about the regulatory landscape.
All right, thank you. So Shira just painted the picture of
why antimicrobial stewardship is so important for us as a society, for as a healthcare entire industry that really can impact care and health for generations to come. And as you mentioned, the government's really stepped in because it's more than just a clinical problem. It's a public health problem. So with the government stepping in, there have been a couple of mandates that require that there are antimicrobial stewardship efforts. The way that's most tangible for long-term care is through the Federal Register, which we think of as the mega rule. Now, here I've highlighted from phase 2, which was mandated as of November 2017, a couple of requirements specific to antimicrobial stewardship. So all long-term care facilities are now required to perform a facility-specific assessment of their resident population and facility to assess for risk level. Additionally, and kind of more tangibly, it is required that there is an antimicrobial stewardship program at every long-term care facility, and that antimicrobial stewardship program needs to include protocols both for how to use antibiotics, so antibiotic use guidelines and protocols, as well as protocols surrounding how to monitor antibiotic use and how to conduct this antimicrobial stewardship program. So there's a couple of nuances that need to be addressed in meeting these new requirements. So the minimum requirements, as I mentioned, for these protocols, there needs to be at least 2 of them. One of them is stating that you have an antimicrobial stewardship program, who is involved in that program, what are the activities of that program, and then there needs to be at least one additional protocol that helps with antibiotic use, appropriate antibiotic use. These protocols need to be reviewed annually and should be somehow involved with your infection control program. There needs to be some sort of a system for monitoring antibiotic use. You get to dictate when that happens, whether it's when residents are first admitted to your facility, when they're transferred. You can do it during the monthly antibiotic review or monthly drug review with your pharmacist. It can be fed into your quarterly QAPI meeting. There are various ways that you as a facility can choose to address it, but it needs to be addressed one way or another, and it needs to be outlined in your antibiotic stewardship protocol. Another requirement of the mega rule is that there is some mechanism to provide feedback to prescribers about the appropriateness of their prescribing and whether or not they are complying with facility protocols. It's recommended that this occur with your consultant pharmacist. It should happen at least monthly, and there ideally should be some documentation about this communication because it is an important part of meeting these mega rule requirements. There are several resources available to help meet these requirements and improve and build your antibiotic stewardship program. Reading the Federal Register can sometimes be a little burdensome, and they often refer to the Joint Commission guidelines on antimicrobial stewardship in long-term care. So if you follow the link at the bottom, or it can be emailed out separately, the link for the antimicrobial stewardship guidelines for nursing home and assisted living facilities gives really good guidance on what stewardship program entails, how to accomplish it, and what are the appropriate actions that this group should be taking. These core elements are somewhat mirrored from the core elements for antimicrobial stewardship in acute care, but they're really tailored to the resources and day-to-day practice differences in a nursing home compared to an acute care hospital. Within this website, there's a checklist of those core elements. So that way you can really quickly and easily do a self-evaluation to identify what you already have established at your facility and where you have room to grow. And all of these elements should ideally be addressed one way or another in your antibiotic stewardship protocol. It's ideal to see some sort of evidence of leadership support, ideally from your medical director, with written support of improving antibiotic usage. It's ideal to have somebody who is going to hold themselves accountable or be accountable for being a lead in antibiotic stewardship activities. Every nursing home is required to have a consultant pharmacist, but, do you have access to individuals with antimicrobial stewardship pharmacist expertise? That might be your consultant pharmacist, or many facilities may contract with antimicrobial stewardship experts that can really help improve antibiotic usage at a patient level. Shira and I served as antibiotic stewardship consultants to a local long-term acute care hospital. By providing that antibiotic stewardship expertise, the facility was able to decrease costs enough to the point where they didn't need us, and they were able to justify in-house resources to that. So identifying whether or not you have antibiotic stewardship expertise and who that may be should go into your antibiotic stewardship policy. The stewardship team should identify at least one action to improve antibiotic use. And that can change over time, but there should be at least one action in place. And along with that, some mechanism of tracking that action. There also needs to be generalized monitoring of antibiotic prescribing, and some mechanism of feeding that back to the prescriber, so that way they have an understanding of what their appropriateness is. And lastly, there should be some ongoing education for all clinical providers on staff. We recommend on hire and annually, but just some way for all staff, including the nursing staff, to really be engaged with antibiotic stewardship principles. Sorry. Another great resource comes from the Choosing Wisely campaign, which comes out of the American Board of Internal Medicine. Within Choosing Wisely, they have a various list of appropriate interventions for the long-term care population. Some of this relates to antibiotic use, and some of it doesn't. But in conjunction with AMDA, the Society for Post-Acute and Long-Term Care Medicine, they've identified 10 things that really could help improve appropriateness in long-term care. So that can involve, not giving a percutaneous feeding tube in a patient who has advanced dementia, instead offer oral feeding. So really just improving appropriateness of care. But there's some antibiotic associated ones that also are worth looking into. So, by improving the appropriateness of care, you can somehow also avoid the need for antibiotics. So we all know that using urinary catheters increases the risk for having a urinary tract infection and therefore needing antibiotics. However, if a patient only has a urinary catheter because of incontinence, well, there are other mechanisms for managing urinary incontinence that don't increase the risk of a patient's urinary tract infection and thereby don't increase the risk of them needing antibiotics. In addition to improving the risk for infection, also improving your diagnostics. So if a patient has nonspecific symptoms, sending a urine culture may identify bacteria in the urine, but it doesn't necessarily mean that the patient has a urinary tract infection. We will talk at length in future webinars about the role of colonization and how it can serve as a red herring from misidentifying the patient's actual problem at hand. Additionally, other areas where you could find colonization besides the urine could include the swabbing of a wound. If it doesn't look like it has cellulitis or abscess or necrosis and you obtained a wound culture, what you'll pick up is colonization that lives on top of that wound that isn't necessarily causing any infection. And lastly, C. diff tests can remain positive for weeks to months after patients have completed their therapy and clinically resolved. However, if you retest, you will often get a positive again. So in a patient who has already clinically responded, you should never resend a C. diff test. Other areas in which antibiotics aren't needed is a positive urine culture in the absence of any symptoms. We call that asymptomatic bacteriuria. Cloudy urine and foul-smelling urine does not count as a symptom of a urinary tract infection. And we'll be speaking at length in May on the importance of really delineating what is a urinary tract infection. Additionally, there can be colonization of bugs in upper respiratory tract infections, and we also know that most upper respiratory tract infections are caused by viruses, not bacteria. So giving antibiotics is not only not helpful, but could also have some harms associated with it. If a patient has an abnormal chest X-ray without any signs or symptoms of respiratory infection, giving antibiotics is not helpful because there are likely other causes for that chest X-ray abnormality. Patients who have diarrhea with a negative C. diff test may have diarrhea due to alternative causes, potentially infectious and potentially non-infectious. And whenever a patient has diarrhea with a negative C. diff test, empirically treating is not really useful. What's most useful is doing a thorough screening of any acute changes in diet, in medications, in various things that could affect a patient's diarrhea. And lastly, mental status changes, which is often viewed as a diagnostic criteria of a urinary tract infection. However, patients who have dementia are going to have predictable waxing and waning of their mental status. So if a patient does have an acute deterioration in their mental status and they have a known ongoing diagnosis of dementia, it's worth considering whether or not that's just part of the predictable fluctuations within the context of their long-term diagnosis. So what we've really laid the foundation here for the basics of antibiotic stewardship, but I want to pass the ball back just to highlight that we have several webinars coming up. So I'm going to pass it back to Elise.
Yes. Thank you, Shara and Kara. Great. So it doesn't look like we have any questions at this time, and I'll just move on to final announcements before we close today's webinar. Don't forget to mark your calendars with the remaining webinars for the series. Webinars take place monthly through September, and check out our website for more information or contact your state lead to help you with registration. And the contact information will be at the end of the webinar. And moving on to the next slide. Also, don't forget to follow us on social media to get all the important alerts, news, and more. Sorry, here just going right back to this is our contact lead, contact for our state lead. And if you have any questions that you weren't able to get to today, you can go right ahead and contact your state lead. And thank you so much for joining, and have a great day.